The point is we are definitely interested into these complex interactions between, on one hand, cognitive abnormalities that we know could be risk factors but also could be damaged by depressive episodes. We also know that they might alter the way we are able to function in every day. So the main question is, how are these three concepts integrative, and how can we act as clinicians on these aspects? Maybe we should begin by saying that these cognitive aspects, which might be neuropsychological approach of depression, and the functioning level, which is more about the social psychological impact, are in fact, first of all, the aspect for which it is interesting and important for patients. So when we talk about cognitions, when we talk about functioning, these are the words that the patients quote when they talk about their disorder. I want to be out of the disorder because I want to improve familial relationships, I want to increase the number of social contacts, to improve my physical health, to find a partner. All of these are priority points, and all of these correspond to functioning, so this is definitely an interesting point. When I'm saying that these three concepts are being completely mixed, it means that it might be a bit difficult to disentangle the role of each of one. There was one study which was nice because it looked at both clinical symptoms with or without a current depressive episode, and then what was the level of cognitive function, and also how were they rating their quality of life and functioning in everyday life. And they clearly showed that there is an interaction explaining why the arrows goes in each direction. Not systematically all aspects of life that are damaged, not systematically all aspects of cognitions, but at least one aspect is being touched by the other one. So we can say that clinically, whatever the kind of relationship, there is a tight link between these three concepts. Probably the best way to look at how cognitions could be a marker of depression or a risk factor of depression is to look at the concept of endophenotypes, which means the healthy relatives who are first degree of a patient who had depressive episodes. Do they have normal cognitions? There's been a large number of studies, usually on a very small amount of relatives, small amounts of healthy controls, meaning that the capacity to detect any specific difference was not so clear. So there is now this large meta-analysis, and as you can see here, nearly all of them are being significant. So that means that we have a difference for those healthy relatives. I'm the brother or the father or the sister of somebody who had a depressive episode. I never had it for me, but nevertheless my cognitive abilities are lower than the average. So it could be shared within the family and then considered as a risk factor. But the other way around is also demonstrated. While you have a depressive episode, especially if you stayed on a long time being depressed, then your quality of life, your capacity to go back to usual functioning is being damaged. And so you are not going to function as the other ones, even though you have no remaining symptoms, completely full clinical remission. And that was nicely demonstrated in the Spanish study where they said that those ones that stayed very long, nearly a year being depressed, even though they have absolutely no remaining symptoms, they do have a damage on the level of functioning. So this is a scar, it is a risk factor, sometimes really difficult to make the difference. So we made this study on a very simple cognitive task. Everybody knows with this one, TMTA. You have between 1 and 25 in circles. You have to pick up where's number 1 and then draw a line up to 2, then find number 3, draw a line, and up to 25. Usually it takes around 30 seconds to do that for a healthy subject. When you're depressed, you get slower. You have cognitive retardation and motor retardation, so you're slower. But when you get response, of course, you're much quicker, very close to what is observed in healthy controls. But in fact, this is true only for first, second, and third episodes. And afterwards, your quality of remission is being damaged, and you keep a little bit of slowness at the cognitive and the physical aspect of it, meaning that you have a kind of scar effect. too long, too many depressive episodes, slower way and capacity to use your brain. And of course, that would mean also higher vulnerability, which might explain then why we make always more and more episodes with time. This was also demonstrated recently in another aspect of cognition, which is sustained attention, what we could call concentration, focusing on something and keeping doing that exactly same thing all around. This study is really for very young kids. You are required to look at letters that are D but not P, and you might quote this item because it is surrounded by 2 dots. If it's 1, if it's 3, wrong. It's a P, wrong. So only when it's a D with 2 dots, you have to quote it. And you have to do that 45 times for each line, and there's 45 lines. So, it's really boring. So it means you really have to concentrate, to sustain your attention on a specific task. And what we showed is that it is relatively stable with time. It's not really directly impacted by depression, but the level of sustained attention you have highly predict your capacity to get not only to clinical remission, but also to functional remission. Once again, the cognition abnormalities within depressions predicts functioning. So these are once again really correlated. So then we are a bit mixed. Is it a scar or a risk factor? It's always difficult. So if we're not a believer about endophenotypes, there's another way which is very easy now, which is this fantastic approach of polygenic risk score. You might not be completely aware of this aspect, even though I'm in a biological congress, but this polygenic risk score is really a kind of, for me, one of the revolution in psychiatry. So we really have to look at that because fantastic studies are now coming out for that. You know that this is a GWAS, genome-wide association study, from chromosome 1 up to the sexual chromosomes. And you look at the dots. Each dot is the p-value. When I'm within this chromosome, in this locus, in this specific gene, with this specific SNP, is it higher in patients compared to controls? If it's very different, then the p-value is very high, the dot is high. And it's absolutely not different, then it's exactly the same, p-value is 0. And so usually we've been working on these, the big stars, the SNPs that were so highly more frequent in patients compared to controls, that yes, this SNP, then this gene might have a role in the disorder. With polygenic risk score, we don't care at all about those big stars. Because why is it? Because those little dots there, they are highly significant, each of them. But altogether, the global variance they explain is miserable, less than 1%. And then if you skip to the thousands and thousands of SNPs there, each of them not significant. Boo. You cannot say that this gene is really involved. Yes, but each of them brings a little bit of the total variance. And this can be up to 20 to 30% of the global variance of the disorder. So it tells much more compared to these big stars. And that's the polygenic risk score. And what is fantastic with the polygenic risk score, you have a kind of identity genetic card of each disorder or concept, and then you can compare it and see exactly how they are fitting or not. That's one example where the executive functioning was studied in a large sample of young students. You make a GWAS of that, and then you look at the exact equivalent GWAS for major depressive disorder, and you see if these two are matched or not. And as you can see here, the correlation between these two polygenic risk score is between 10% and 20%, 0.1, 0.2. Not huge, but incredible, because this is real SNPs heterogeneity. This is not about a kind of global marking. That's real facts, physical facts. So yes, there is a correlation. It's a small one, but it's a significant one, meaning that the SNPs that are involved in your executive functioning capacities are partly shared by the SNPs involved in major depressive disorder. So that's probably a good way for me to answer the point. But of course, here we are also interested in how we can act on that and not only how to understand it. And of course, we have a lot of different antidepressant treatment, which is the most validated technique in order to improve patients. What is interesting for me is 2 aspects. The first one is some antidepressive treatments are extremely efficient on depressive disorder, monoamine oxidase inhibitors and tricyclics, but they also have cholinergic effect or lateral effects that damage cognitions. And of course, where the impact on one of these tests, which is a digit symbol substitution test, a very simple test where you have letters and symbol, and you have just a list of letters there, and you have just to switch to symbol. And as you do that again and again, you memorize them, and then you get quicker. So it solicitates your flexibility, because you get from one to the other one, and your memory skills. And altogether, it's quite sensitive to the damage of depression on the brain. And so when you have these kind of very efficacious treatments, you might have a negative impact on cognitions, for example, for sedation or cholinergic effect, and then you lose benefits on these cognitions. So of course we need some time to do that, because the patients are so depressed they even cannot use their cognitions. But before that, it's always better to try to avoid it. And then we have the benefit of SSRI, SNRI, and the multimodal ones. For them, and especially for the multimodal one, having a kind of strange activity which is beyond the efficacy on depressive symptoms, but also directly on cognition. With this new approach of ketamine, which was so fantastic for clinicians, there was a very nice study showing that, it was published in Science just a couple of weeks ago, where they just showed that in fact, when you create a model of depression in rats, where you increase cortisol, you increase a little bit of stress, you might in fact damage the level of mobility of not the patient, the rat, because it is a model of depression, and this is blocked by the injection of ketamine. And if you see how the patient has an improvement of its neuroplasticity, it's largely enhanced by ketamine. And what is, as you can see directly here, I could put it there, with the stress of your constraint, you lose a lot of these dendrites, and after these 2 weeks of stress or cortisol, whatever the model, only 24 hours of ketamine, and you see there's sprouting of new dendrites, which will facilitate new types of connections. So it's also a nice model, because we know that it might have the connection between neuroplasticity and cognition is very obvious, that maybe ketamine is doing that more quickly than the usual antidepressants, because it acts directly on neuroplasticity, not indirectly, and then of course it's quicker. There are other strategies that's linked to the title, saying that what can we do to touch these difficulties in different ways. I listed some of them quoted in the literature: the cognitive remediation therapy, physical exercise, yoga, mindfulness, neuromodulation. We're doing a lot of that now in my department, and we have very interesting result where mindfulness might improve cognitive flexibility, explaining why they facilitate also, but it's not yet completely published. So the other approach, which is also very important for all of us, for our patients with depression, is sport. I don't know if you have the experience of that with your patients, but usually patients say, I don't like sport. And if you push them to do sport, for them it's stressful, and then it's more damageful. So it's a bit difficult to see how we can use sport to improve cognitions, which will improve cognitive depressive symptoms. The first of all is to be convinced ourselves. To be honest, how many of you systematically propose to your depressed patients to do a little bit of sport? Not so many. But that's for good reasons. You know, we know our depressed are sad, they don't feel worth, they're not able to even go out. How can they do a little bit of sport? So the first point is really sport active for all depressed patients? And the answer is clear. Yes, have a look there. Any kind of sample, the old one, the ones having diabetes, hypertension, the ones that have no practice, so all of them will have a benefit of sport. So that's probably, for me, the most convincing one. It's not specifically for those that already like sport. It's for all kinds of patients. The other aspect which is important is that, do we have some evidence that sports might really improve cognitive flexibility and attention process, explaining how they could help the efficacy of antidepressant treatments? And yes, we do, just the same. All the 5 cognitive skills that were tested according to a practice of sport was highly correlated. So yes, sport facilitates cognitions. That's the last example, which is more at a clinical level, showing that in Barcelona, here, they took 2 samples, one getting in the very busy part of Barcelona, where are lots of cars, bumps, traffics, and stress, and the other one in the very beautiful park where you have a nice walk in tree quiet environment and very nice. And we see the patients afterwards, all of them being depressed, half of the sample. And as you can see here, after the walk compared to before, you have an improvement of moods when it's in nature, largely reduction of negative emotions and increase of positive emotions. And that's much more obvious when it's a nice surrounding. And even more, when you look at cognitive skills, which is the DBS, where you have to memorize the numbers that were given, not just there, but the one before, which use your memory skills, it is also improved. And so for me, this is a very important lesson for us clinicians. If you ask your patient to go jogging, to do a jogging just downstairs in the middle of Paris, Milano, or Naples, it's a nightmare. Don't do that. They won't like it. Then it's a stress, and you increase the severity of depressive disorder. So that's why it has to be smooth, it has to be nice, it has to be social. But it has to be real sports, because usually a lot of patients say, oh yes, I'm walking. But it has to be a little bit of walking. And for that, these nice watch now are very important, because it shows that if your heart rate is not increasing, you are not doing sport. You are having a walk. Why not? But this is not sport. So you have to increase a little bit of your heart rate. And if you do that, then you would have a large benefit. I know that you are now completely fine of this polygenic risk course, so now we can use it now about how can we connect physical activity and MDD. Because we made a genome-wise for anything on Earth. Just one team publishing it, it's available for the whole publication and of all type of studies. So now with this polygenic risk score, we can compare whatever map of the identity of the phenotype we're looking at. And as you can see here, the SNPs that facilitates more sport activity are also reducing the risk of depressive episodes. Fascinating, isn't it? It means really that, all this capacity to use oxygen, to solicitate your muscles, is probably also using your brain. And altogether, you are improving your depressive episode if you're depressed, but also your capacity to get out of it, of remission, because you will use more cognition, then more functioning, and then more activity, which means higher chances of clinical remission. I will end this talk on CBT, which is another alternative we use a lot for depressive patients, especially when they have remaining symptoms, and to just once again test this interaction between clinical symptoms and cognitions. For that, we've been giving a list of words, neutral, positive, or negative, and 10 of each of them, a table, a chair, a war, target, whatever. But some of them are really negative, strike, divorce. So some of them are very nice, I don't know, football or weekends, party. And then you have to memorize them. Usually patients with depression, they memorize quite a few ones, 12 out of 30, very small. Very interestingly, we found that the more depressive episodes you have, the higher you are able to memorize those negative words. Interesting, because that means it's more qualitative than quantitative. And when you have some remaining symptoms, you are more focused on what is in accordance with your own mood. And of course, you memorize more easily those words that are really important for you, because this is what you feel. But after 4 months of CBT, you have an improvement. So you increase your cognitive skills altogether. But have a look at the qualitative level. You increase neutral words, you increase positive words, but you decrease the number of negative words you're being seen. And as you modify this number, then it is not more significant. So for my psychology, they were so proud to say, we are now the only one able to demonstrate that we tackle the scar effect of past depressive episodes. So whatever, it is interesting to see that we have this kind of improvement. So just to conclude, it is a trio, cognition, functioning, and depression. They are related dimensions. Are they already always rated and monitored by each of us and given back to each patient? Not exactly. This is really silly. I mean, how can we make patients aware of their importance if we even don't give the results to the patient? Yes, it takes a little bit of time because you have to explain it, but it's so interesting because you give this kind of weapons to the patient. It is both a trait and a state effects, which makes things a little bit difficult to understand by patients. it is both a quantitative and a qualitative effects of depressive symptoms damaging cognitions, which will impact functioning. And the vicious circle can be modified into a virtuous circle. You take more pleasant and social physical exercise, which will increase your mood, which will facilitate cognitive stimulation, which then will increase your quality of life. And of course, that will mean, to conclude, that you have to treat early, effectively, and long enough. That's the best way to protect the three of them. Thank you.